Contact dermatitis, understanding causes, symptoms, and management. Contact dermatitis is an inflammatory skin condition triggered by direct exposure to irritating substances or allergens. Learn about its types, risk factors, and evidence-based treatment approaches. What is contact dermatitis? Contact dermatitis represents one of the most prevalent inflammatory skin conditions encountered in clinical practice. This disorder develops when the skin comes into direct contact with substances that trigger an inflammatory response. Unlike many other dermatological conditions, contact dermatitis is neither contagious nor inherently life-threatening, though the resulting discomfort and disruption to daily activities can significantly impact quality of life. The condition manifests through various cutaneous signs that range from mild to moderate severity, depending on the causative agent and individual susceptibility factors. Types of contact dermatitis. Medical professionals recognize two primary categories of contact dermatitis, each with distinct underlying mechanisms. Understanding these classifications helps guide appropriate diagnostic testing and treatment selection. The differentiation between these types has important implications for predicting recurrence patterns and implementing preventive strategies. Healthcare providers must accurately identify which type patients experience to provide targeted management recommendations. Key points: irritant contact dermatitis occurs when skin barrier function is compromised by direct chemical or physical damage from substances, independent of immune system involvement. This represents the most common form of contact dermatitis and can affect virtually anyone exposed to sufficient concentrations of irritating agents. Common irritants include detergents, solvents, acids, alkalis, and friction-inducing materials. Allergic contact dermatitis develops through a delayed hypersensitivity immune response in individuals who have previously become sensitized to specific allergens. The initial sensitization phase may occur without visible symptoms, but subsequent exposures trigger a localized immune reaction. This type requires prior exposure for sensitization to develop and affects only individuals who have developed specific immune reactivity against the triggering substance. Clinical presentation and symptoms. The clinical manifestations of contact dermatitis present across a spectrum of severity, influenced by exposure intensity, duration, and individual factors. Patients typically report symptom onset ranging from minutes to several days following exposure, with the timing depending on whether the reaction represents irritant-induced or immune-mediated inflammation. Early recognition of characteristic features enables prompt intervention before symptoms progress to advanced stages. The distribution pattern of lesions frequently provides diagnostic clues regarding the causative agent and exposure mechanism. Key points: pruritus ranging from mild itching to severe, intense urges to scratch represents one of the earliest and most bothersome symptoms experienced by affected individuals. Erythema or redness of the affected skin areas, which may be localized or extensive depending on exposure circumstances. Xerosis or skin dryness, contributing to compromised barrier function and perpetuating inflammatory processes. Papules and vesicles that develop in response to continued inflammation, often arranged in patterns that reflect the shape of the offending agent. Common causative agents and triggers. Identification of the responsible triggering agent proves essential for successful management and prevention of recurrent episodes. A comprehensive history documenting potential exposures, occupational hazards, hobby-related contacts, and product usage patterns assists clinicians in narrowing the differential diagnosis. Certain substances account for the majority of contact dermatitis cases, though individual susceptibility varies considerably. The prevalence of specific triggers varies geographically and temporally based on product availability and occupational patterns within different populations. Key points: occupational exposures including metals, nickel, chromium, cobalt, industrial chemicals, cleaning products, and construction materials affecting workers in various industries. Personal care and household products containing preservatives, fragrances, surfactants, and other chemical additives commonly found in cosmetics, soaps, and detergents. Plants such as poison ivy, poison oak, and poison sumac containing urushiol oil, a potent allergen affecting susceptible individuals through direct or indirect contact. Metals and jewelry components, with nickel representing the most frequent allergenic metal encountered in fashion accessories and fasteners. Risk factors and vulnerable populations. Certain demographic, occupational, and physiological characteristics predispose individuals to higher risk of developing contact dermatitis. Recognition of these risk factors allows healthcare providers to offer targeted prevention counseling and early intervention strategies. Age, occupation, atopic status, and prior sensitization history collectively influence susceptibility to both irritant and allergic mechanisms. Environmental and genetic factors interact to determine individual threshold levels for developing symptomatic disease. Key points: occupational exposure to irritants or allergens presents a significant risk factor for workers in healthcare, manufacturing, agriculture, cosmetology, and construction industries. Atopic dermatitis or other chronic skin conditions compromise skin barrier integrity, reducing tolerance to irritant substances. Prior episodes of contact dermatitis or sensitization to known allergens increase likelihood of recurrent reactions upon re-exposure. Compromised skin integrity from wounds, eczema, or other dermatological conditions facilitates penetration of irritant and allergenic substances. Diagnostic approach. Accurate diagnosis of contact dermatitis relies primarily on clinical assessment and carefully obtained historical information regarding temporal relationships between exposures and symptom onset. Physical examination findings correlate with the distribution and morphology of lesions expected from the suspected causative agent. Diagnostic confirmation frequently requires specialized testing when the responsible agent remains unclear despite thorough history taking. Patch testing represents the gold standard for identifying specific allergens in allergic contact dermatitis cases where avoidance and prevention strategies hinge on precise identification of the triggering substance. Clinicians should inquire about timing of symptom onset relative to potential exposures, occupational and hobby-related activities, recent product changes, and seasonal variation patterns. Lesion morphology and anatomical distribution often suggest likely culprits, for example, facial involvement with cosmetics, hand involvement with occupational exposures, or linear patterns suggesting plant contact. Patch testing involves application of standardized allergen solutions to intact skin, with subsequent evaluation at predetermined intervals to assess delayed hypersensitivity responses. This testing modality demonstrates superior specificity for allergic contact dermatitis compared to clinical diagnosis alone. Management and treatment strategies. Successful management of contact dermatitis emphasizes identification and elimination of the offending agent as the cornerstone of therapy. While pharmacological interventions provide symptomatic relief, the most effective long-term approach involves avoiding further exposure to the causative substance. A layered treatment strategy addresses acute inflammation, restores compromised skin barrier function, and implements measures to prevent future episodes. Treatment intensity should match disease severity, with mild cases often responding to conservative measures while moderate to severe disease may require systemic therapy. Key points: avoidance of identified triggers through conscientious attention to product selection, occupational precautions, and lifestyle modifications tailored to individual circumstances. Gentle cleansing using lukewarm water and mild, fragrance-free cleansers to remove potential allergens and irritants without further compromising barrier function. Application of emollients and moisturizing products containing occlusive agents to restore skin barrier integrity and alleviate xerosis. Topical corticosteroid preparations appropriate to body site and disease severity, reducing inflammation and providing symptom relief during acute flares. Prevention and long-term management. Prevention of contact dermatitis recurrence requires sustained vigilance and practical implementation of exposure avoidance strategies adapted to individual circumstances. Once sensitization occurs, individuals typically remain vulnerable to reactions upon subsequent exposure, necessitating permanent behavioral modifications. Educational counseling addressing proper skincare, product selection, and environmental controls substantially reduces recurrence rates. Occupational health considerations prove particularly important for workers exposed to professional hazards, where coordinated approaches involving personal protective equipment and workplace accommodations optimize outcomes. Key points: careful product selection emphasizing hypoallergenic, fragrance-free formulations specifically labeled as suitable for sensitive skin. Use of protective equipment including gloves, protective clothing, and barrier creams in occupational or recreational settings involving known irritants or allergens. Regular skin care maintenance with appropriate moisturizers and gentle cleansing protocols to maintain robust barrier function. Awareness of cross-reactive substances and chemically related allergens that may trigger reactions despite avoiding the primary sensitizing agent. When to seek professional medical evaluation. Most cases of contact dermatitis resolve spontaneously following exposure cessation, but certain clinical scenarios warrant professional medical assessment. Signs of secondary bacterial infection, extensive body surface involvement, facial or genital involvement, or symptoms persisting beyond expected timeframes should prompt dermatological evaluation. Healthcare providers can facilitate accurate diagnosis through specialized testing, implement evidence-based treatment protocols, and provide guidance for preventing future episodes. Early professional intervention prevents progression to severe disease and reduces long-term morbidity from chronic inflammatory changes. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.